start. Okay. So go ahead, Dr. Bisuru.
I hope my slides are visible.
Yeah.
Yes, yes.
You can see clearly.
Yes.
Okay. So just give me a second. I need to. Good afternoon, everyone. So, at the outset, I would like to thank the organizers for giving me this wonderful opportunity to participate in this great initiative where we are trying to interact amongst ourselves and learn EEG from each other. So, today's topic is just a second. I don't know why the slideshow is not moving now. Are the slides moving?
Go to the next one.
No, I think I'll have to keep the topic. Yeah, the topic for today is focal and generalized epilepsies. So how we are going to progress in this presentation is that we would like to look at common generalized epilepsies, common focal epilepsies, how there are signature EEGs available for each generalized epilepsy condition and focal epilepsy condition. And we would also try to see how the epileptiform discharges on EEG would look different in a generalized epilepsy from a focal epilepsy. So I will primarily focus on the generalized epilepsy syndromes and the focal epilepsy syndromes, which are pharmacoresponsive, because epileptic encephalopathy and drug responsive epilepsy will be handled by a different speaker. So moving on to the next slide. So when we talk of generalized epilepsies, so these are the common generalized epilepsy syndrome that we encounter in a pediatric age group. So this includes classical absence epilepsy, which has salient clinical features in the form of onset of 5 to 7 years, episodic behavioral arrest with automatisms. Then we have some form of complex classical absence syndrome. So one is Juvenile syndrome, in which there is again episodic behavioral arrest, which is so commonly seen with absence epilepsy, but they would also have ocular and perioral myoclonia. So we would be seeing some, classical videos, classical EEGs, these things will become clearer, but this is just an initial slide to sensitize the audience. Then we have another common syndrome seen with absence epilepsy, which is known as Tasinary Syndrome. It shows episodic behavioral arrest with axial myoclonia. Then we have juvenile absence epilepsy. Because the classical absence epilepsy is around 5 to 7 years, the juvenile absence epilepsy is between late first decade and adolescence, characterized by episodic behavioral arrest. But compared to childhood absence, one would see generalized tonic-clonic seizures and myoclonic jerks with juvenile absence epilepsy. With juvenile myoclonic epilepsy, it's again a 12 to 16-year age group epilepsy. The common epilepsy form here is myoclonic jerks, but one would also see GTCS and episodic behavioral arrests. And then we have the primary or the idiopathic generalized epilepsy, which doesn't fit into any of these syndromes, which again comes in late first decade in adolescence, and the commonest seizure semiology is GTCS. This slide is important from this point of view that we need to understand that what are the generalized epilepsy syndromes that we encounter in pediatric age group, what are the common clinical features associated with them, and then how EEG signatures are present for each of these syndromes, and how this will help us in diagnosing all these conditions. Now, moving on to the next slide. Dr. Praveen, the slide is moving. Can you see the Eeg Epoch?
Yes, yes.
I can see the EEG forms, yeah.
Yeah. So if you look at this EEG, this is a classical EEG of a childhood absence epilepsy. So what is there? These are single epochs, because I think I am coming quite late into the workshop. So most of you would be aware now how to look at an EEG epoch. So we have these 10 seconds, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds, each second having this frequency, which is read at each second. And you can see this spike followed by slow wave, spike followed by slow wave. So around 3 hertz spike and wave that is classically seen with absence epilepsy, childhood absence epilepsy. So this is a signature EEG snapshot. So now what I'll do is I'll move on to the next slide. I would stop sharing this PowerPoint and I'll move on to some videos and show you some classical videos so that it becomes a bit clear to all of you. So let me me stop sharing here. And what I'll do is I'll open one of the videos. So I think, yeah. So Dr. Praveen, is the video visible?
Clearly, hello. We
Yeah.
can see.
Yeah. So if you see, we are doing a hyperventilation maneuver in a child in whom we are suspecting childhood absence epilepsy. Now you can see this child is doing hyperventilation. So this is one of the common ways of making the child understand how to do hyperventilation. They blow onto a piece of paper. So this is a child who is listening to us, is conscious, is hyperventilating, and we saw normal EEG waveform. Now please keep an eye on the EEG waveform on your right. So as you see, this child goes into behavioral arrest. And the moment he goes into behavioral arrest, you can see this classical generalized discharges, 3 Hz spike and wave. The child has stopped hyperventilating. He is into behavioral arrest. There is continuous generalized. There is no, preponderance towards any particular electrode. It's a generalized discharge, 3 Hz spike and wave. And now look at what all the child is doing. So these are all automatisms. The child is picking onto the piece of paper. Look at the EEG, and then you can see he's picking his clothes. There are some subtle orofacial movements. Then he is again picking onto his clothes, classical automatism seen with childhood absence epilepsy, child in behavioral arrest, 3 Hz spike and wave, continuing on EEG. And then I would just, now that you have seen this part, I'll slightly take it forward. As you see, the EEG has normalized, and now look at the child as if he was absent from the world for that point of time, and then he again comes back and starts hyperventilating. So this is the classical, clinico-electrographic correlate of a child with childhood absence epilepsy, one of the commonest generalized epilepsy syndromes. Okay, so now I'll stop sharing this and I will share my presentation once again. Okay, so now let us move on to the Dr. Praveen. Are the slides visible now?
Yeah, we can see.
Okay. Yeah. So now moving on to the next slide, this is a summary slide of EEG in generalized epilepsy. So this is very important. So before going on to the other complex, epilepsy syndromes, I thought that first let us understand what do we see in EEG in generalized epilepsy. So we started with classical absence epilepsy, generalized discharges, 3 Hz spike and wave. Okay. Now the next one is Juvenile syndrome. So you see 3 Hz spike, polyspike and wave discharge. But what is important here is lid closure. So they have eye closure sensitivity. On hyperventilation, you will see what you see in childhood absence, but you would also see the similar findings on photic stimulation. As we move forward in the presentation, this will become clearer. Then we have Tasinary syndrome. Routine EEG would show again 3-4 Hz spike and polyspike. Then you have again spike and polyspike on hyperventilation and similar finding on photic stimulation. Juvenile absence, you will see 3 Hz spike and wave on both hyperventilation and photic stimulation. Juvenile myoclonic, you will only see with photic stimulation. And primary generalized epilepsy, you will see generalized discharges with routine EEG, with hyperventilation, with photic stimulation, but there won't be any accentuation with hyperventilation or photic stimulation. Now, before moving on to the EEGs, let us just observe 2 more videos and these syndromes will become clearer to us, more clear to us. So again, it will take me 1 or 2 minutes to show you the videos. Dr. Praveen, I hope it's visible.
Yeah, we can see.
Okay, so I talked about eye closure sensitivity or lid closure sensitivity seen with Juvenile syndrome. So again, you will see when we ask this child to close his eyelids, he gets into behavioral arrest, and you can also see what I mentioned, oral and ocular myoclonia that is classically seen with Juvenile syndrome. Why we need to identify this semiology is because Many times these are falsely diagnosed as focal epilepsies. So just see the EEG again, just see the clinical semiology again. He closes his eyes, he goes into behavioral arrest, and he has this eyelid myoclonia. So this is classically seen with Juvenile syndrome.
Otherwise, he looks like it may be a case of absence epilepsy, no?
Yes,
That
sir. Yes, sir. Yes, sir. Juvenile is a type of absence only. So this is another interesting EEG and clinical correlate. So I just told you about Tasinary syndrome. So many times the way parents describe Tasinary syndrome, they would come and tell you as if the child is having GTCS. But it's a type of absence in which, apart from behavioral arrest, the child has axial myoclonia, myoclonia of the trunk and limbs, and then classical 3 Hz spike and wave. I will just show you the clinico-electrical correlate and it will become clear. So just see the video. So again, the child is hyperventilating and you see what happens. This axial myoclonia of the trunk and the limbs and the classical 3 Hz generalized spike wave discharges. So these 3 videos, the idea of showing you these 3 videos were to show how classical absence epilepsy looks like, how Juvenile syndrome looks like, behavioral arrest, eyelid myoclonia along with eye closure sensitivity, and this Tasinary syndrome where you see axial myoclonia with hyperventilation and classical 3 Hz spike and wave on hyperventilation. Now we don't have any further videos to see, so we'll move on to the slide presentation. Okay, so now that we have gone through this, now let us look at this EEG. So this is a typical EEG, which is an awake record. You can see this posterior dominant alpha. I've kept the montage at average montage, that is a referential montage, so that it becomes clearer it is coming from which part of the brain. So you can see this posterior dominant alpha activity. Now moving on to the next slide, the same thing is continuing. This green mark is marked for hyperventilation and this yellow mark is marked for photic stimulation. So let us move on to this next slide. So you see the moment the child has started hyperventilation, the cursor is here. So it is the hyperventilation has started in the green mark. You can see this occipital predominant spike and wave discharge is coming. So an important point to notice here that I'll talk about intermittent rhythmic, delta activity in focal epilepsies a bit. I'll touch upon there. But one also needs to understand that even in generalized epilepsy syndrome like absence epilepsy, when you start hyperventilating, the initial manifestation may be some occipital, spike and wave activity or just delta activity, and then eventually it builds into 3 Hz spike and wave. So now moving on to the next epoch, it is still building. You can see this occipital spike and wave and some delta activity. And now as hyperventilation is full-fledged, you can see this 3 Hz spike and wave activity. I slightly increase the sensitivity because from 70 to 200 to make the morphology clearer. If you see, there is not just 3 Hz spike and wave. You can see these areas of polyspike, multiple spikes together. So on hyperventilation, 3 Hz spike and polyspike wave activity. Now this yellow part is photic stimulation. And you see the same thing with photic stimulation. To make the morphology clearer, we slightly increase the sensitivity. And you can see this 3 to 4 Hz, 1, 2, 3, 1, 2, 3, and some polyspikes in between. 3 to 4 Hz spike, polyspike wave activity also with photic stimulation. So both with hyperventilation as well as photic stimulation. This again with slightly higher photic stimulation, that is 16 Hz. Again, when we increase the sensitivity just to understand the morphology better, you can see this 3 Hz spike and wave with photic stimulation and some polyspikes embedded in between. So this is an EEG. If a child comes to you with episodic behavioral arrest and you see 3 to 4 Hz spike and wave discharges, polyspike along with spike in hyperventilation as well as photic stimulation, it will either fit into juvenile absence or Tasinary or Juvenile, but depending on clinical semiology, that was the reason for showing you the videos, and also eye closure sensitivity, which will become clearer in subsequent EEGs. So clinical and EEG taken together will be able to make a primary generalized epilepsy diagnosis. Always remember, if you're dealing with a generalized epilepsy syndrome, it's not just awake record which is important. Along with awake, you need to do hyperventilation and photic stimulation to characterize the syndrome better. Now we'll move on to the second EEG. So again, simple posterior dominant alpha rhythm you can see in the first epoch. Second epoch, you can see the cursor is hyperventilation. Nothing has happened on hyperventilation. It's a classical posterior dominant alpha rhythm going on. Now, as we move on to the next epochs, you see what is happening. We have reached photic stimulation, and you can see this posterior predominant generalized spike polyspike wave discharge. It's a bit crowded because the sensitivity is 70. So we'll move on to slightly higher sensitivities. It becomes clearer. Now you can see it's more of polyspike, and the frequency is slightly more, not 3 hertz. Here it is reaching up to 4 to 6 hertz. You can appreciate it better. Spike, polyspike, spike, slow wave, spike, polyspike, slow wave. So when you have 4 to 6 hertz, generalized spike, polyspike activity, primarily on photic stimulation, nothing happening on hyperventilation, you should think of juvenile myoclonic epilepsy if it fits clinically. So again, how activation procedures help us in differentiating various primary epilepsy syndromes on EEG. Now we'll move on to the third EEG pattern. So again, this is something interesting. We have seen juvenile absence. We have seen juvenile myoclonic. We had initially seen childhood absence. Now just see what is happening here. If you have gone through your artifacts, this is a classical eyelid artifact. It happens when we close our eyelid. And see what is happening. Moment there is eyelid closure, you see this burst of generalized discharges. Eyelid closure, burst of generalized discharges, classically seen with Juvenile syndrome. So again, eye closure sensitivity. Okay, now moving on to the next slide. See, this becomes clear. I have slightly increased the sensitivity. You can see this eye closure artifact. You can see this 3 hertz spike polyspike generalized activity precipitated by eye closure syndrome, eye closures. So this is eye closure sensitivity, classically seen with Juvenile. You come to hyperventilation, you again see 3 hertz spike polyspike wave activity. It continues on hyperventilation. I slightly increase the sensitivity for better understanding of morphology. You can see this classical 1, 2, 3 to 4 hertz spike polyspike generalized activity seen with hyperventilation. Similar things seen with photic stimulation, increasing the sensitivity, better identification of morphology. So again, you see eye closure sensitivity, 3 hertz spike polyspike slow wave activity with hyperventilation, similar finding with photic stimulation. And so we can characterize here Juvenile syndrome. So we understood childhood absence classical, then juvenile absence, then juvenile myoclonic, and then we also understood Juvenile syndrome. Tasinary, we had already seen the video and the corresponding EEG. So I've just kept the summary slide once more. Classical absence epilepsy of childhood, you will see routine EEG, generalized discharges, hyperventilation, 3 hertz spike and wave discharges. Just run through the slides I showed you, you will be able to remember. Juvenile syndrome, you see this 3 hertz spike polyspike wave discharge on lid closure, similar finding on hyperventilation, similar finding on photic stimulation, our last EEG. Tasinary syndrome, on generalized, you see 3 to 4 hertz spike polyspike, hyperventilation, photic. But how do you differentiate from Juvenile? One is your lid closure, and the other is the classical semiology of axial myoclonia. We saw it in a video. Then you have juvenile absence epilepsy. We saw in EEG, generalized discharges, routine EEG, 3 hertz spike and wave, both with hyperventilation and photic stimulation. Juvenile myoclonic, you see 4 to 6 hertz spike, polyspike and wave discharges that we saw in one of the EEGs. And then in primary generalized epilepsy, which otherwise doesn't fit into any of these and mainly comes with GTCS, you see these generalized discharges even on routine record, on hyperventilation, on photic stimulation, but it doesn't get accentuated by either hyperventilation or photic stimulation. So through these slides, I tried to, show to you in a brief span of time, how do generalized discharges look like? What are the common generalized epilepsy syndromes which come with generalized discharges on EEG, and how hyperventilation, photic stimulation, and a simple clinical maneuver like lid closure, eyelid closure helps you in differentiating between various types of childhood epilepsy syndromes, which fits into primary generalized epilepsy. Now, from generalized epilepsies, let us move on to focal epilepsies. So if you see, the first thing that I'm starting with is a summary slide. So which are the common ones? You have Rolandic epilepsy, 4 to 3 years, facial twitching, hemiclonic or hemidystonic hand movements. You have centrotemporal spikes with tangential dipole. Don't worry. The first slide is just to sensitize you. Then we'll see few EEGs, and the last slide will help you in summarizing and retaining whatever I'm trying to tell you. Then you have penatipolis and gestor. Both are types of childhood occipital epilepsies. The penatipolis comes early. You have more of autonomic and behavioral disturbances, vomiting, eye deviation, unconsciousness, and tonic-clonic movements. On the other hand, gestor is later half of first decade. They would come with visual aura and hallucinations that would be there at the onset. Now, what is classically seen with EEG? You see occipital spike and wave activity. Of course, their occipital epilepsy will see this, but then you can demonstrate fixation of sensitivity. That means this discharges, they disappear with eye opening and fixation, because the occipital lobe is focusing on fixation at that time, and it is induced by eye opening and closure. It is induced by darkening and closures. This eye opening is a typological mistake, so I'm sorry. So attenuation by eye opening and fixation, and induced by eye closure. So once you ask them to close their eyes, the discharges would come back. So this classical fixation of sensitivity seen with occipital epilepsy. Then you have some other focal epilepsy syndrome like autosomal dominant nocturnal frontal lobe epilepsy. So again, because it's frontal lobe, they're brief, hypermotor, tonic seizures primarily happening in night and can present from childhood to entire life. Interestingly, the interictal EEG is normal, and you have ictal bifrontal activity when the child has an ictal record. Then one more entity, it's an epilepsy syndrome associated with MRI abnormality. You have mesial temporal lobe epilepsy with hippocampal sclerosis. You have the classical epigastric aura. You have ipsilateral automatisms and contralateral version and hand dystonia. Once the discharges spread to frontal lobe, these motor manifestations are seen contralaterally, and you see temporal discharges. So this is just to sensitize you. Now just let us understand how the discharges on routine EEG for generalized epilepsy differ from focal epilepsy. Okay, so we move on to this. So this is classically a bipolar montage. You have FP1, F3, then F3, C3, then C3, P3, then P3, O1. So if you see, there is a negative deflection. So this downward deflection is for positive, and this upward deflection is for negative. So try to understand that when you have a bipolar montage, FP1, F3, F3, C3, C3, P3, this kind of a phase reversal that happens common to a particular electrode actually localizes the epileptogenic zone. So here, if you see C3, so F3, C3, C3, P3, you have a phase reversal. So this phase reversal would tell us that the localization is towards C3. Just to make you understand, if it is FP1, so if it is F3, C3, so that means F3 is more positive than C3, and you see a downward deflection. So C3 has some negative amplitude. C3, P3. So C3 is more negative than P3, so you have an upward amplitude. So if you think of the overall negative amplitude of C3 here and here taken together, that is causing the phase reversal. So phase reversal, bipolar montage, your localization in focal epilepsy. Again, then we can come to referential montage. Don't worry. We'll soon see some EEG snapshots and this will become clear. Now see what has happened. Moment from bipolar, we go to referential, where everybody is against a particular reference. You see the highest amplitude is with C3, and so the localization is to C3. So in bipolar montage, localization is by phase reversal in focal epilepsy, and in unipolar, referential or average montage, the localization is by highest amplitude. This will become clearer soon. So let us move on to this slide. So if you see, so you have, this is F4, C4, you have C4, P4. So you have phase reversal happening here. This is a phase reversal. This is a phase reversal. This is a phase reversal. Although in P4O2, you also see discharges. The phase reversal is happening in F4, C4, C4, P4. C4 is common. So most probably our focus of the focal discharge is C4. Let us see the next slide and it will become clearer. Highest amplitude, C4. You can see something in FP2, something in F4, something in P4, but the highest amplitude in C4. And this is a referential montage. All are against the A2, A1 electrode. So bipolar, phase reversal. Referential, highest amplitude, helps us in localizing focal epilepsy. Okay. Now, if you look at this, this is a classical benign childhood epilepsy, centrotemporal spikes. But before going on to the signature EEGs, first let us understand what we see in bipolar and in reference, and then it will become clearer. Now you see we again have a bipolar montage, phase reversal FP2, F4, F4, C4. So the phase reversal is at F4. So the irritated zone is the F4. Okay, so this is how, if it's a bipolar montage, FP2, F4, F4, C4, C4, P4, the electrode where phase reversal is happening is the culprit, the focus for epileptogenic zone. If it's a referential montage, then the highest amplitude. So this is a classical benign childhood epilepsy centrotemporal spike. Slightly, let me increase the size of the EEG. It will become clearer to you. As I said, so there is a phase reversal at C3. So you have a spike and wave discharge in C3. And if you look at corresponding FP1, F3, you have surface positive. That is why it's a downward deflection. Frontal surface positive, downward deflection. C3 surface upward deflection, surface negative. So this is classically seen with benign childhood epilepsy, centrotemporal spike or Rolandic epilepsy, a tangential dipole. That is, from surface, you have a surface positive coming from frontal, which has downward deflection, and deep from central, you have upward deflection, a surface negative. So a surface positive and a surface negative discharge gives rise to a tangential dipole, classically seen with Rolandic epilepsy. Now this slide, this is showing you classical childhood epilepsy, occipital paroxysms. That is what I talked about, Penatipolis and Gestor. This is how the EEG would look like. You will see this runs of discharges, C3O1, T3O1, O1A1, T3. So you can see primarily it's O1 electrode, which is common, and showing these runs of discharges of spike and wave seen with childhood epilepsy with occipital paroxysms. Look at this. Again, you can see this is an average montage. So we'll look at the one with maximum amplitude. Maximum amplitude is there with F3 or C3. So if maximum amplitude is not there, if all of them are showing equal F3, C3, T3, so that means it is more of a frontocentral, left frontocentral temporal irritative zone. Why? Because all three have same amplitude on average montage. So you're actually not able to localize. So all three are showing same amplitude. This is an average montage. Okay, this is your classical temporal lobe epilepsy. You can see this is an average montage. Just slightly increase the slide size of the becomes clearer. Yes. So you can see these are all, this is all T3, T501. This is average, maximum amplitude, and T3 and T5. So this is classical left temporal epilepsy. Why? Average montage, maximum amplitude. Again, an average montage, but here the maximum amplitude is with frontal, F8, T4, T6O2. You can see some discharges, but it's F8 where the amplitude is maximum. So this is a right frontal focus. Why? Again, average montage, maximum amplitude. Bipolar montage, phase reversal. Average montage, maximum amplitude. Moving on to the next one, I just want to show you an EEG. You see in this entire epoch, you can see something like a phase reversal where FP2, F8, F8, T4. So F8, maybe F8 is our culprit. So this is bipolar, so we are seeing phase reversal. Now let us see, yes, see what is happening in average. You can see typically this spike and wave discharges coming from F8. So we saw in bipolar phase reversal and F8. In average, we saw this high amplitude spike and wave coming from F8. So this is a right frontal epilepsy. This slide again, what can you see? This is again a bipolar montage. So we're not very sure. Some discharges from F4, C4. You can bare minimum see some, phase reversal, but the upper wave is not that prominent. But again, you see something here at F8, T4. So we're really not sure once we see the bipolar montage because we're not able to appreciate the phase reversal properly. It could be F4, it could be F8. We are not very sure. So we move on to average montage and see what do we see. This is your FZ, this is your F4, and if you see FP2, very small, and you don't see anything on F8. Why? Because the main culprit is F4. So when we saw in bipolar, we were not able to appreciate that much of phase reversal. There was some doubt here, but the upper wave was not that well formed. So we thought maybe F4, but not very sure. Could it be F8? But then when we saw the average montage, we classically saw this high amplitude, average montage. So we look at the highest amplitude, it is F4, right frontal epilepsy. Okay, so if you remember, I had talked about rhythmic delta activity. which happens in generalized epilepsy, beginning of hyperventilation seen with childhood absence. Now, this is classically seen also with focal epilepsy. So it could be an occipital rhythmic delta activity. Look at this. All of a sudden, there is this rhythmic delta activity happening. It could be there in temporal, it could be there in frontal. So all of them may have epileptogenic potential, rhythmic delta activity, and particularly seen with focal epilepsy. In childhood, more commonly FIRDA and OIDA are seen, that is frontal and occipital rhythmic delta. Here, interestingly, this was an NCC case. You can see this delta activity in both right and left occipital electrodes, and you can see this embedded spike and wave also seen with right occipital electrode. So you can see the focus as well, spike and wave, and you can also see this intermittent rhythmic delta activity that can be seen in the occipital electrodes because of the underlying substrate. Now, just to give you an idea, the same child, this one is average showing the delta activity with some embedded spikes. After some time, we could classically see the spike and wave activity coming from the right occipital electrodes. So some rhythmic delta activity telling us that this could be the focus, and this getting confirmed by the spike and wave discharge. So rhythmic delta activity helps in localization in focal epilepsy and can be seen in the beginning of hyperventilation in generalized epilepsy starting from occipital. So just moving on to the last summary slide for focal epilepsy, so that whatever I've shown you, you can just recollect it once. Rolandic epilepsy, clinical feature 4 to 13 years. You have facial and hand twitching and dystonic movements. You see the classical centrotemporal spikes with tangential dipole. So what do you see? You see upward deflection in centrotemporal electrodes, downward deflection in frontal electrodes, and that leads to a tangential dipole. Then you have penatipolus and gestort. We've already discussed about the clinical features. Routine EEG, you will see occipital spike and wave activity, which demonstrates fixation of sensitivity. That is the moment the eyes are closed, you start seeing the spike and wave discharges. Then you have nocturnal frontal lobe epilepsy, where you can see some frontal activity. I showed you how to localize on bipolar montage using phase reversal, and then a reference montage looking at the maximum amplitude, the way you can localize frontal and temporal lobe epilepsy. So thank you for a patient hearing, and now I'm open to questions. So I'm done with my presentation about focal and generalized epileptiform discharges. Thank you again to the organizers for this wonderful opportunity.
No, thanks. It was wonderful, Dr. Vishnu. Always mesmerizing kind of presentation.
Thank you.
Yeah, definitely. It was very nice, and you had kept plenty of illustrations to deal with that. So I just asked for one or two questions that Dr. Praveen has already answered, but still
I think
like
we can have we can have input from Dr. Vishwarup also. What does he feel about the part?
definitely about
Can
what do
you on the
you
chat box?
About voltage map or frequency map or spectrum graph. What do we infer from that, and
Okay.
how much it is?
So, see, what happens is, as I told you, the visual approach that we have classically, what I just discussed, is the best way to look at an EEG. You know, we look at an epoch. It's a 10-second epoch. We see each second in that epoch. When it's a sleep record, we try to look at the sleep markers. When it's an awake record, we look at the awake posterior dominant alpha. And then if it's an abnormality, we try to characterize it into generalized or focal, whatever way we want. Now, if you're talking about spectrum graphs, and so spectrum graphs primarily help us in seeing what is the maximum frequency at a particular place, what is the maximum amplitude that is coming at a particular place. Now, these have more of research connotations. In routine day-to-day management, in routine day-to-day reporting, we should classically look at a landscape 10-second epoch and try to just do it the way manually we do it and report it, because these may give us some hint towards which is the most dominant frequency, which is the most dominant amplitude. But what we can see by looking at the entire tracing and then correlating it clinically, that is the best way to do. So spectral waveforms and other things may be helpful, but more for research purpose. For routine EEG reporting, we should always follow a routine visual approach and manual reporting.
So
Great.
In fact, I'll just add one thing. I feel that whatever our Indian machines are giving on the spectrum part, it is something like when you get the ECG report through the, you get the ECG and they send with the report also with the ECG, the PR and the QRS, and you have to look at those reports because they're not entirely correct on the part. So that's the personal part.
Definitely.
That's wonderful.
So at this point, I would like to draw attention of our delegates. I have few announcements to make. The offline part will be having, that we have arranged one EEG machine properly, new branded EEG machine, and there will be one biomedical engineer, and there will be two subjects demos and one technician, and the whole process of doing EEG and what the instrument requires, its maintenance part, or what you have to do. So it is all going to be very clear on hands-on basis. Uh, it will be, you will like it definitely. And one more thing, that our thought is that most of you, of course, you are getting so much interest, and for continuously for 4 days we are just brainstorming over the topic of EEG, which is not usually taught as much in our PG curriculum. So I think if 10% or 20% of this gentry starts doing EEG, then our purpose will be solved. What you say, Praveen?
That's good.
Isn't
I
it
mean,
like
this is very different. I mean, once you develop the interest, I have got two things to say. So we wanted also Dr. Visrup to be on there on Sundays, but I think he has got some engagements. That's why he could not come. It would have been really nice to have him there. And second, that definitely, I mean, once you start developing the interest, then you take yourself further in the course. So you definitely self-improve yourself. You start reading the things. You start, I mean, relearning the things. You start, I mean, enhancing your skills. So that's a good way to move further. So we encourage
okay?
that.
And so
And
our
that's a purpose also. Yeah.
another announcement is that you will be given small but very useful handout of EEG. Our you can say that it will be nutshell, EEG in a nutshell, very 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 handy. And third thing is that we will be providing you physically certificates there, so please be there. And on Saturday, though our session EEG course is not there, but on the occasion of World Autism Day, we have planned a very good chat show, with the likes of great developmental pediatricians like Dr. Monideepa Banerjee from UK, and Dr. Praveen Suman from she is from NCR region, Delhi NCR region. And Dr. Sunil Godbole from Pune, Dr. Priyanka Jan from Meerut. That will be a great chat show, and it's not about management of autism. It's something in different perspectives. Like we are going to have a chat show with points covered. What a pediatrician can do to manage parental exhaustion and parental frustration in managing autistic children. Number one. Number two, the important aspect will be there are different myths and realities in management of ASD. And last but not the least, most important by them, that there what are the newer innovative ideas to manage these children in a different way, because autism जितनी सारी बातें इसके बारे में बुक्स में है, उससे 10 गुनी ज्यादा बातें लोगों की बातों में है. तो क्या उसमें से उठाना है क्या नहीं, सिर्फ 1 घंटे का प्रोग्राम है, वही 4 to 5 p.m. I would like all of you to join that. So this much announcements to be made, and now I request Dr. Praveen to go ahead with his presentation regarding anti-epileptic drugs. Though it has not to take with EEG, but this is very contemporary topic, and there are a lot of changes in the choice, as well as there are newer drugs indications. So we will have a bird's eye view over newer anti-epileptic drugs. So Dr. Praveen, please take over.
Okay. So thank you very much once again, boss, and I really appreciate your all endeavors. I mean, never with all the energies. I mean, managing these ones and then autism and all the part that requires a different kind of energy. So really, a round of applause for that. So right, I mean, we didn't have this topic in the beginning, but as you suggested that because we are talking about the EEG epilepsy and it will be slightly different. and maybe of more of practical importance. That's why we included this topic in the last of our EEG programs, not in the beginning part. So just in brief, we all know that we have been using anticonvulsant medications since many, centuries. In fact, one of the first anticonvulsant was fasting, which Jesus used to give it to his patients with the seizures. And fasting is still being used as a kind of like ketogenic diet in treatment of refractory epilepsies. So the potassium bromide, which was the first anticonvulsant, it is still being used in veterinary science, and we also use it a couple of times in our refractory epilepsies like Dravet syndrome. So if you look at the part, our older AEDs, or what we call them as an established AEDs, the sodium valproate, the phenytoin, the carbamazepine, they all had come before 1981, and they are known as an older anti-seizure medications or established anti-seizure medications. The drugs which came after 1981, they all are called as newer anti-seizure medications. That includes all the medicines like lacosamide, jonicamide, oscarbazepine, levetiracetam, used so widely, and topiramate. So what we'll do that, why do we need to have so many anti-seizure medications? Because we know that even if you add 2 or more than 2 medicines to control a well kind of like diagnosed seizure, still you find that almost more than 30% of seizures or epilepsy are still refractory. They don't listen to the first 2 line appropriate medications. So almost more than 30% still warrant some further medicines to get control of their seizure. So to have better control of the seizure part, that is the first indication. You think about the newer anti-medications to have a better adverse effect profile, because we have learned in the past about the side effects of phenobarbital or side effects of levetiracetam. Then people start thinking, they start reading, and they want even the parents want some different medications with a better side effect profile. And definitely because we manage refractory status also, that we also need to have medications which can be given intravenous, medications which can be rapidly effective, medications which has got less kind of like drug interactions. So let us see what we have apart from all these things which we saw. What I see practically, and what I wanted to give you a kind of like the practical input from a clinician point of view are these couple of medications which I see have really come into our scenario in the recent time: the vivacetam, the lacosamide, the ethosuximide, vigabatrin, perampanel. Other drugs like eslicarbazepine, we don't use so much in the pediatric population. Our adult colleagues do use it. Cannabinoids, they are not still not available legally in India. So I'll try to focus you. A lot of medicines which are already using the levetiracetam part, the oxcarbazepine part, or maybe topiramate or the lamotrigine part. I'm not going to bring a discussion about these ones. I wanted to focus on these medications which I find they are relatively new in the pediatric practice. So vivacetam, we know this is an analog of levetiracetam, but this is supposed to be 20 times more potent, more effective than levetiracetam in the published studies. I'm not very sure in the practical, population use. That's my personal, experience. But they have approved this as a kind of like adjunctive treatment for focal onset seizures in children more than 4 years of age. The vivacetam, and there have been a number of studies about this medication in the recent past, citing its efficacy both in the focal epilepsy and also in the generalized epilepsies. And even they have found that this has been effective in small children also, as I mentioned to you, beyond 4 years of the age. And there have been certain studies where they have found that it was useful even in cases where levetiracetam failed to show a good efficacy or good seizure control. So what is the prescribing information of vivacetam? This is available in the oral form, both tablet and the syrup form. The dose is 2 milligram per kg per day. The max dose is 200 milligram twice daily. We don't require titration, but normally we start in the lower doses. We start with the maybe around 0.5 to 1 milligram per kg per day, and gradually we build up to 2 milligram per kg per day. There is no significant drug-drug interaction, although we need to have a caution about the hepatic dysfunction and the use of these medications in those ones. But more or less, this is a safe medicine on the part. What I find personally, all this has been used in cases of focal epilepsy and the generalized epilepsy both, but practically what I find that this can be used in cases of refractory focal seizures, especially focal cortical dysplasia, where you don't if you don't get much benefit with your baseline medications like oxcarbazepine and those ones. People have used and have got positive kind of feedback in frontal lobe epilepsy. Even a couple of my patients also, they have done well on Bivacitam in frontal lobe epilepsy. That's a thing which practically we have found useful. Cases of children with the autism and ADHD, as Dr. Rajab was also mentioning, they have got a lot of behavioral issues. Bivacitam is reported to be having less behavioral side effects as compared to the levetiracetam. In these cases, you can think of where the child is having some behavioral symptoms, and he's already a case of ASD and ADHD. Adolescent females, because this has been found to be useful in generalized epilepsy, also in JME, because in females you try to avoid sodium valproate, which is the drug of choice. In those cases, you can try Bivacitam in those ones. Epileptic encephalopathy, although there has been case reports of this being useful in the Lennox-Gastaut syndrome, Dravet syndrome, and G1s, as Dr. Vishnu was mentioning about those ones. As an add-on drug, maybe partial effect, partial seizure control, not a kind of like game changer in those cases. And status epilepticus, because you have used so many medications in those ones. Second in the line is Lacosamide. And this I find, I mean, personally, a really useful medication which has come in recent couple of years to our use. This is available both oral and the intravenous form. And this has got a different mechanism of action. Basically, it is acts on the by inactivation of slow sodium channels in these ones. And a good part about this medication is this, that this is also has got a list kind of like side effect profile, list kind of drug-drug interaction kind of thing. The thing to make a note of this medication is about tendency to increase the PR interval, especially if it is being used with drugs like carbamazepine and lamotrigine. So maybe you can do a baseline ECG or keep a check on the heart rhythm, because sometimes they've been found to increase the PR interval. The dose is 3 to 12 milligram per kg per day. We don't go beyond 5 milligram per kg per day. Normally we load with the 5 milligram per kg per day, and we don't go beyond 6 milligram per kg per day of lacosamide in the practical thing. And this is really a good drug. We have been finding it quite useful in cases of focal refractory epilepsy, and useful when our first line agents like oxcarbazepine or levetiracetam has also failed. I mean, that's my practical experience which we have been using in the past couple of years. The good thing that this has got the IV formulation also. If a child comes to you seizing in the emergency, you can give it IV and then you can maintain. Because see, number of drugs, if you look at the drug of choice for the focal epilepsy, it still remains oxcarbazepine or carbamazepine. Fine. And both of them do not have the IV formulation. So once child comes to you with an emergency with the focal seizures, part, you need to have a drug which can be given intravenously if it is still seizing, and it can be, if it can be kind of like maintained also in the follow-up, it becomes wonderful part. This is good about lacosamide because it can be given intravenous formulation in case of acute emergency, and then subsequently you can maintain him on this medication in the oral tablet or the syrup form. Recently they have come of its indication in the generalized epilepsies also. Not sure about the adolescents and the pediatrics, but definitely we try to use it in the epileptic encephalopathies. But we need a lot of literature for the part. The next in the line of medication, which I find has come really, shown wonderful results, is the Exocestimide. Not a new drug. I mean, it has been in use since many decades in different countries, but definitely in India we have been using it for past couple of years. And if you ask me that this is one of a couple of these anti-seizure medications who, if they show effect, they show like a surgeon's effect. So like if a patient is having some serious abdominal pain, a surgeon makes out this is appendicitis pain, he takes out the appendix and the surgeon's surgical pain, I mean the pain vanishes forever. The same thing happens with these kinds of medications, the Exocestimide basically. If a child is a case of like absence epilepsy, and if you put him on the Acetymide, and if he responds to this, it's a wonderful drug. So even in a span of a couple of days, you find that his seizures are totally stopped, and parents are so happy about this medication. The same thing happens sometimes with the sodium valproate. If it starts showing effect, I mean, it's totally, stop the seizures, especially the generalized ones. And sometimes the vigabatrin when it works on the infantile spasm. So this, I mean, couple of drugs, I feel that if they show effect, they really bring the cheer to the patients and their parents. So Acetymide, I mean, the real mechanism is not widely known, but they find that it normally decreases the burst firing of thalamocortical neurons, and that's why it has been found to be useful in the childhood absence epilepsy. The dose is 10 to 40 milligram per kg per day, similar to sodium valproate, oral medications. One company, I mean, as of now, makes in India the absence, the syrup formulation. And apart from the childhood absence epilepsy, which is the number one medicine for this, it can be also used in cases of atypical absence epilepsy and absence status. Sometimes have been found to be useful in cases of JME and Lennox-Gastaut syndrome. I have not used much in these cases, but this is a drug. I think we all, as a pediatricians, should be aware of Ethosuximide, because we see a lot of absence epilepsy. And definitely, I mean, you have to differentiate this as an absence epilepsy versus a kind of like a focal seizure with impaired awareness, because that's another area where we get confused. But once you're diagnosed as a CAE, we just now saw with Dr. Vishwarup, 300 spike and wave, this becomes a wonderful medicine for the part. Last two, the vigabatrin. I have purposefully, I mean, written about vigabatrin because nowadays vigabatrin we are giving in the sachet form also. Initially, we had only one drug, Sabril, and it was difficult to procure, difficult to get. But now, because there are so many vigabatrin in the available in the Indian market, especially in the sachet form, it becomes easier to use, especially once we are acclimated with this medication. This has got a mechanism of action over the GABA, which it causes the irreversible inhibition of GABA and increases the level of basically GABA in the neurons, causing the inhibitory effect. Has been prescribed for partial seizures. I mean, the focal seizures nowadays we call them, and infantile spasms. We use it most often in cases of infantile spasms, especially has been found to be useful as a number one drug in case of infantile spasms because of the tuberous sclerosis, but even infantile spasms because of other etiologies. If the steroid is not active, steroid is not acting or fail to act, you can think about the vigabatrin. The dose is 50 milligram per kg per day to start with in 2 divided doses, and then you can go up to 150 milligram per kg per day in 2 divided doses. So start from the 50 milligram per kg per day, and you can go up to 150 milligram per kg per day in the part. Nowadays, that, I mean, as I said to you, it's coming in the sachet form also, where you have to, the one sachet has got 500 milligram. You have dissolved in 10 ml of water, and you can give it as per the body weight. The vigabatrin part, infantile spasms, especially if it is because of the tuberous sclerosis, this is a drug of choice. And if it is because of any other, etiology, if your steroid has failed, you can think of vigabatrin as an alternative etiology. The most dreaded complication is visual side effects, especially the peripheral vision loss because of damage to the retinal photoreceptors or retinal ganglion cells, which is normally seen in the higher doses, maybe around close to 150 milligram per kg per day, and prolonged duration, more than 6 months of use. Even they have found that children who have used for more than a year, they have remained well. But before you start this vigabatrin, you have to make sure that parents understand the potential side effects of peripheral vision loss, number one thing. And if you can get, it's wise to get the periodic repeated visual examination done. Not very, practically useful in the pediatric population because the peripheral vision field requires perimetry. You require a cooperative child. Most of these cases, infantile spasms are basically epileptic encephalopathic patients. They don't cooperate for the part, but you can have the indirect tests, like you can have the OCTs, the VEPs, or the fundus examination, where your ophthalmic colleague can help you in giving a kind of like clue about the damage to the retina or peripheral visual field on the part. But it's good to include the ophthalmics whenever you are prescribing the vigabatrin in the part, and must mention to the parents about the visual side effects. And last is the perampanel. Still, I mean, this the drug which I found to be useful in the practical sense. This acts on different receptors, AMPA receptors, and it has been licensed as an adjunctive therapy for the treatment of primary generalized tonic-clonic seizures and focal onset seizures. So have been used in both the conditions, the generalized and the focal one. The good part about this drug is about a long half-life. You only need to give once a daily dosing, and the world biology is very, very good as the eye formulation, and you can give it only once a day. In the part, dose is from 2 milligram to 12 milligram. You start with 2 milligram per day at night, and gradually you can go up to 8 to 12 milligram at night. Only one dosing is required. It can be combined with any of these current available anti-seizure medications. The perampanel, available in many forms, many brands have come now recently, and still there are a number of studies of role of perampanel in refractory epilepsies. Even people have tried in cases of Lennox-Gastaut syndrome, West syndrome, Dravet syndrome with this medication. Even with the Dravet also, we also have used in a number of our patients, and the results have been partially successful, I will say, because they have been found to be reducing the seizure, may not be making it as seizure-free, like I mentioned to you in certain cases of Acetymide induced absence epilepsy remission or valproate induced, but it has been found to be useful in the literature also, and in the personal practice also in different kind of epilepsies. And mostly that even in cases of epileptic encephalopathy, it has been found to be useful. The Lennox-Gastaut I just mentioned to you in the cases. So advantage is about effectiveness in partial onset and primary generalized seizures. So that's a good thing. It's broader spectrum on the part. Single daily administration, not measure of cognitive side effect on the part. And although there has been mention about the possible psychiatric adverse effects, we do come across at times the laughing episodes and the slightly hyperactivity tendencies. But if you keep a dose to on the minimum side and gradually increase, chances of it having are on the lower side. So to conclude, this is a good drug. We need to see where you can place it, especially because it's got a different mechanism of action, and it is a broad spectrum medication useful in both the primary generalized and the focal epilepsies on the part. So in a nutshell, if you look at the older AEDs and then the newer one, in terms of efficacy, more or less they are same. Adverse effect, they had different kind of, these have got different kind of adverse effect. Definitely they are less enzyme inducers, the newer ones. They are broad spectrum, as you say, like oxcarbazepine, carbamazepine. They are very particular about the focal seizures. The phenytoin you can't use in the generalized epilepsies, but they are mostly broad spectrum on the part. That's why this is very useful, and they are useful especially in cases of where you have drug-drug interactions, like children with the hematology, leukemia, and those ones where you can't put them on medication which affects their chemotherapy. In children who have got a status, you need some IV medications. Children who have got some refractory seizures, you need some drugs with a different mechanism of action to combine them together. So they are useful, they are an adjuncts, and they give us an expanded treatment option to manage our epileptic patients. In a nutshell, generalized seizures, drug of choice is sodium valproate, focal is still oxcarbazepine. You can think about lacosamide also, as I mentioned to you. I personally use it sometimes, preferring before oxcarbazepine also, the lacosamide one. Unknown onset, sodium valproate is a time-tested medication, especially if a child is more than 2 years of age and you're not sure about if you're sure that it's not a metabolic or mitochondrial kind of pathology. Neonates is still phenol is the drug of choice. And what you need to know also is to avoid medications like phenytoin, carbamazepine, oxcarbazepine in children who are having generalized seizures, because they may aggravate the seizures in these cases. You all know. I just want to mention about the oxcarbazepine, because that is a good drug for focal onset seizures, focal epilepsies. I didn't mention because we have been using this medicine for many years. The dose is 5 to starting dose is 5 to 10 milligram per kg per day. Normally we start from the lowest possible dose, 5 milligram per kg per day, and you can go up to 30 to 40 milligram per kg per day. But the trick is to start on the lower side, not on the 10 side. It's always wise to start on the 5 milligram per kg per day to avoid the potential side effects of like drug rash, Stevens-Johnson syndrome. So when you choose a medication, what you think is more about the drug toxicity, means that just now we mentioned about we don't use medications which can aggravate the behavioral effect in cases of autism, ADHD, like levetiracetam. You try to avoid medications which has got more of a drug interaction in children with the leukemia or hematological cases. In those ones, patients, depending on the patient's note, child is slightly on the higher side of the weight, you try to avoid the sodium valproate because it can gain weight on the part. And seizure characteristics, we saw that if it is generalized seizure, you try to avoid drugs like carbamazepine, phenytoin, and oscarbazepine. So you have the medicines with you, you know about the medicines, it's knowing about your weapons which you have with you, and you have to select it, you have to make it individualized depending upon all these things. You're not causing more harm to the patient, what is the patient profile, what he'll benefit the most, and what kind of seizures he's getting. And seizure characteristic, as we have been seeing, requires both the witness account and a good quality EEG to make sure this is a focal seizure or generalized seizure on the part. So thank you very much. I think we are done with this one. And
thank you very much, sir, for the mesmerizing talk. I think so. Dr. Ajay sir is somewhere busy, so is not available.
okay.
Are you there, sir? Ajay sir?
I think he's mute or what?
Sir, are you mute?
एक्चुअली कल का जो है ना शेड्यूल, कल का शेड्यूल ये रहेगा कि अभी तक हम लोगों ने जो कुछ डिस्कस किया, उसके बाद एक इम्पोर्टेंट टॉपिक रह जा रहा है, दैट इज नियोनेटल ईईजी. तो नियोनेटल ईईजी पे अभी तक बात नहीं हुई. लास्ट में क्यों हो रही है? वो इसलिए हो रही है कि नियोनेटल ईईजी थोड़ा सा ग्रे एरिया है, उसके ऊपर थोड़ा सा थोड़ा एडवांस चीजें हैं, उसके ऊपर ध्यान देना होगा. उसके बाद जो सेकेंड पार्ट ऑफ लेक्चर है, मतलब दैट इज मिसयूज एंड लिमिटेशंस, उन सारी चीजों के साथ हमारे फैकल्टी चारों पांचों जितने हैं सब लोग रहेंगे. डॉक्टर प्रवीण, विश्वरूप, डॉक्टर गोस्वामी, सब लोग रहेंगे. एंड दैट विल बी एन अनऑफिशियल चैट शो टाइप ऑफ थिंग, कि क्योंकि ऑफलाइन में आपको ये लोग नहीं मिलने वाले हैं, 2-3 लोग इसमें से, तो सब लोगों को अपना पर्सनली कुछ पूछना चाहेंगे तो पूछेंगे. दैट विल बी अबाउट 20-25 मिनट. वो प्रॉपर इंटरेक्शन के लिए हम लोगों ने सोचा है कि उसको रखें. सो 4:30 to 5 PM, आधा घंटा जो है वो कंप्लीट, दैट विल बी टोटली इंटरैक्टिव. जो आप पूछना चाहो रिगार्डिंग ईईजी एंड एपिलेप्सी वो पूछ सकते हो. दिस इज लास्ट मिनट चेंजेस. ठीक है?
Starting at 4.
क्यों डॉक्टर प्रवीण, ठीक आइडिया है ना?
वेरी गुड.
क्योंकि इंटरेक्शन का टाइम नहीं मिल पाएगा ना प्रॉपर्ली.
पर्पस हमारा वही है कि जितना इंटरेक्शन हो, जितने डाउट्स हमारे स्मॉल डाउट्स हो, डाउट्स तो स्मॉल या बिग भी हो सकते हैं. एंड
लोगों को ये भी लगता होगा कि जितनी सारी चीजें हो रही है प्रैक्टिकली क्या वो इतनी इम्पोर्टेंट है, लाइक जो भी बात हो रही है सिंड्रोम्स की और ये वो. लेकिन होता क्या है ना कि जब आप उस चीज को जानते हैं तो एक आपका वो चार्जिंग होता है. फिर नॉर्मल जिसको फेब्राइल सीजर है, पता चला उसमें आपने कराया और सोचा ईजी को उस तरह से एवेलुएट किया तो कुछ और भी निकल आया. तो बहुत सारी अंतर. कल हम लोग बात करते हैं इसके बारे में. टिल देन, बाय बाय.
Bye bye.